As she was dizzy, if you remember. This is one of the symptoms. For laboratory testing, the culture, if you chose for positive cultures, but not always has to be positive, and also negative for other serologies that can explain these symptoms. This is another one. So, anything about this case?
Just a question.
Ah.
So, how often do you encounter a patient with influenza who's got a very high fever that's worsening over the course of
all the
3
time
days, with a blood pressure of 90-95, with feeling dizzy, with having a diarrhea?
Yeah.
Some people call that a toxic shock.
No, Dr. Well, this is a very nice question. First of all, the pain, yeah, I agree with you. Yes, we encounter that all the time. Patients come with high fever and body ache. It's not localized in one area. Most of the time it's bilateral when they have the body ache. That's one thing. And the other thing, you will have some respiratory symptoms, some GI symptoms that makes you, and the season as well. So you test them for influenza and you find out the diagnosis. But if I want to tell you about patients who come with this severe pain and you don't see the explanation for that, I'll give you many cases. One of the cases, actually this one is another case similar to that, but completely different diagnosis. But I'll give you examples. We have patients who presented in emergency room with irritability. Kids are maybe few months old, like 10 months, 12 months old. And the way they present, they are in pain. We don't know where the pain is coming from. You test everything. You do abdominal ultrasound, everything. One of them ended up being diagnosed with leukemia, and her pain was basically bone pain. And the onset was sudden. So until we did all these investigations, unfortunately, the blood count, which is supposed to give us the diagnosis within the first hour, was not reported right away because they kept seeing abnormal CBC and they request to repeat and repeat and repeat. So repeated like 3 times within 12 hours till we get the results. So this patient was worked up head to toe and then we found out it was leukemia. Another patient also presented to our emergency room, again with a lot of pain and screaming. He was also 10 months old. And basically the first question we asked the family if there is anybody with COVID, and they denied. We did the workup and we want to do spinal tap and everything because he was so irritable, and actually he ended up having COVID, and he had body ache with that, and he was extremely irritable. So these cases we face every now and then, but we aim to do this one. Sometimes it's something even much like something more trivial, like a hair tourniquet. I don't know if anybody is familiar with this. Sometimes kids have like a hair around their toe and they have a lot of pain and irritability. That's why we always have to look for that. And they cry for some time, but then eventually they start crying because they don't feel the pain anymore. And if it was not noted, it will end up with being gangrenous, and they might use a toe or something. So these cases of severe pain is kind of common in pediatrics, and the differential diagnosis always is difficult. But when you have somebody with pain out of proportion, this is the key. When you see a lot of pain but no visible or a lesion that is looks like so minor because this much pain, we have to think about this one, especially with the combination of other things. Basically, I want to convince myself that this patient was not in shock, but truly she was, because when you look at everything else, being dizzy, hypotensive, like putting things together, make you think like it's good that you discovered this in timely manner, and we were able to take her to ICU and give all these blood transfusions and stuff. Yeah, please.
Sorry, I have a question about the pathophysiology, because with necrotizing fasciitis, you have multiple organisms, especially one is immunocompromised, and then the surgery needs excision. But for this, was it only fasciitis and myocytes rather than necrotizing? Because if there is necrosis,
I don't think it reached to the point to develop necrosis. What happened is she had the pain. At the beginning, there was no clinical symptoms, but second, third day, when she started having the swelling, the MRI showed the compartment syndrome, and then they did these 2 openings to relieve the pressure, and they did not have to do, they did some debridement, but it was not like as bad as you can expect with necrotizing fasciitis. So we think at the beginning the pain was due to myalgia, and then the compartment syndrome developed.
So you think
Question. Culture we mentioned here. Did you culture? I didn't see any.
Yeah, they cultured, but it did not grow anything because the blood culture did not grow for sure. The site culture also did not grow because she was already covered with all of these antibiotics. The surgery was done much later than this.
So the
Yani,
samples were taken before the.
yeah, because the minute we suspected the toxic shock syndrome, the vancomycin and the meropenem were on board, especially after we got the the blood coagulation profile and it showed the derangement. So she was sampled on everything until we got the surgeon to do the surgery for her, which took another 24 hours. So none of the cultures grew anything.
How long you
We
treated
treated her, I believe, for 10 days. I wrote it somewhere. I think we treated her for 10 days. Yeah. She received 10 days of treatment.
in the hospital?
In the hospital, yeah. She spent 2-3 days in ICU, and then when she's completely stabilized, she was transferred to the ward and discharged from there. So should we move on to the next one? Okay, this is another one with fever and leg pain, and you can imagine seeing this patient like a few weeks after the first one. So he's 10-year-old male, and he's previously healthy. Again, he came with severe leg pain on the left side this time. And the back side of the ankle, and the back side of the ankle, exactly where I'm pointing. This is when I saw him in the clinic. He was just pointing at one area that is extremely painful, and it was radiating to the calf for the past 24 hours. And it was getting worse. Again, there was no trauma, and the review of systems was negative. So this was the presentation to the clinic. Then his physical examination, he has fever. So of course I was very scared when I saw this one after that case. And he was just crying because he could not bear weight on his leg. There was no tenderness, no swelling, and the skin was intact. So he was just pointing at that area in the back of his leg or foot. And the rest of his physical examination is unremarkable. So again, what do you expect that I'm gonna do?
CBC.
What is it?
Disciples, I mean.
Oh. Yeah, but this will give fever.
In the context of samples, rheumatological disease. Every rheumatological.
Yeah, of course, rheumatology is there, but anybody who comes like with the new onset, rheumatology is not the first on our list. It comes later.
This looks tendon vein.
But something
Yes,
in
muscle
that
tendon.
area. Actually, I
Tendon
can.
Achilles also.
Okay, I'll tell you what happened.
Yeah, so it's the same thing.
I put my differential, but this time we added the toxic shock syndrome because I was afraid if it was the same like the previous patient.
Did he receive antibiotic?
Nothing. He
Tenilons?
truly came, even they were
No.
not aware about
Tenilons.
fever. He just have the pain, and when we saw him in the clinic, we found that he has
Sport
fever.
injury excluded?
لا ما في تروما.
No trauma.
Sport.
Yeah, no trauma. Well, let me tell you what happened. So again, for me, I was scared because I had that case maybe a few months back, so this was scary to me. So I admitted him, and I thought, okay, fever, tachycardia, but I can't go by this one again because he has severe pain, so you cannot use this as one. So we agreed to do labs, and these were his labs: CRP less than 1. Blood culture was sent, quality blood count is good. So that's kind of reassuring, but still we were afraid that what's going on with him with this much pain. So again, we did also the renal profile, LFTs from the beginning, they were normal. We want just to make sure we are not missing another toxic shock syndrome or something. And then we did the imaging studies, X-ray, the MRI and the ultrasound were considered, basically ordered, but not done because other symptoms appeared. And that's why we did not do it. So what happens now? The initial treatment, again, supportive treatment, I started on clindamycin thinking it could be any kind of infection and to monitor for the progression of the condition. So, hospital day number 1, like 12 to 24 hours later, the fever was still there, blood pressure stable, heart rate okay, but he developed rash. He developed rash on the left foot, it's ill-defined erythematous, mainly on the foot, and few on the calf. Pain is persistent, no other symptoms.
Only the left.
Only left. If it was both sides, what can you think? If it's both sides, pediatrics should know. Huh? yeah, it's a good idea. Most of the time it doesn't present with so much pain, but the notional line purpura can. The notional line purpura can present with the joint pain, and then the rash will appear and explain. But this was unilateral, so it's kind of against it. So this rash, that's how it appeared. So any ideas? Okay, well let me tell you about what happened to this rash, because for us also, we kept him and we kept monitoring. We considered the notional line purpura. We were looking if anything will happen on the other side, especially his labs were reassuring. Again, the temperature, look at these lesions, it is spreading now.
Is it thick? Is it nerve bus? Is it herpes?
Okay, great, yeah. It was something like that, because it's on one side and it's following the nerve distribution. Exactly, so they were small papules now, Christian vesicles, so it was still evolving. Pain is persistent, no other symptoms.
Herpes zoster.
Yeah, so we thought about it. And we thought, okay, this is herpes, let's start cyclovir. And of course, we took samples to see what we are dealing with for chickenpox and for herpes simplex. Then this is how the rash looks like. These are real pictures. This is from the patient himself. The rashes start looking like vesicles now. So what do you expect now? This will stay on one leg, is that right?
For herpes, yes.
Okay. Well, that's what happened. Developed visible rash now on the trunk.
Oh.
Everywhere. It was what's going on with this child. I don't know. I mean, usually if it is, it's like chickenpox. Honestly, it looks like chickenpox.
Monkeypox.
No, it was no monkeypox. So we expected, okay, we found the diagnosis, we give the cyclovir, and now it is all over. The fever is 39, and the clusters of vesicles on erythematous space extending from foot upward on the calf and thigh, and then developed this rash also on his trunk as well. So it looks like chickenpox, but usually you know it the other way around. Like chickenpox, after a while it can cause this herpes zoster or shingles, but this time is the other way around. So we start pushing the mother about vaccination. According to her, she is fully vaccinated, but we don't have his records anyway. So the vital signs remain stable, no distress, no central nervous system, LFTs, renal function, everything is normal. And he's on 5 days and he's improving and discharged. Now, he was follow-up. We wanted her to bring the immunization record just to let you know about our immunization schedule. We give the children chickenpox vaccination at 1 year of age, and we repeat at 4 years of age. Most of the time, sometimes, I won't say most of the time, sometimes the child develops a mild disease before 4 years of age, then there is no need to give a second dose. If you don't give the second dose, their immunity with time will reduce, and they are able to develop chickenpox, and it can be even severe disease. So that's why we have to give 2 doses. So with this child, we don't know if he received his medication or not, his full immunization or not. But when we looked back in the literature, this disseminated varicella infection has been described in immunocompromised patients. So it's not unusual for somebody to have an older infection and then get shingles and then have a disseminated varicella. But also there were rare reports that even immunocompetent patients can develop disseminated infection. So this for us was new. We don't know what happened with this child. We think possibly he has partial immunity gained with 1 dose of varicella, and with time the immunity went down. He developed this shingles, but he's not fully immunized against varicella, so he developed disseminated disease because the child is not immunocompromised, and the mother, she followed up, so we could not do any further immune workup. So any question about this one? I don't know in adults if you see
did
cases
the
or not.
serology of the varicella?
We did not do serology. We did the skin test only, and but serology it was not done.
Why?
I don't know.
We usually do for
Yeah, maybe that was a good idea to do it, but I did not do it at that time. I was hoping family will come up with their records and see.
I'm not a pediatrician, but I suspected herpes right away. So the first thing, varicella, IgM.
We commonly see it in adults in dermatology.
You see both together?
Sometimes rarely we see it, but they present with pain, severe pain.
Oh, with pain, exactly. That's the same thing with this one. Yes. Uh-huh.
These people you mentioned that they are immunized once into a booster if they get the disease.
Oh, they immunized one. They get the first injection at 12 months. If we don't give a second one, with time, like the immunity that they received from the first one, they kind of become subsided, and then they develop chickenpox disease maybe at 10, 12 years. In other terms, like you kind of delay the disease itself. When the chickenpox vaccine was first used, they used it as one dose only. But then after 5, 6 years from using this vaccine, they noticed that some of the children who received one dose, they start developing chickenpox at an older age. So they end up having a second dose at 5 years of age as a booster. So you need two of them to make sure that you are fully immunized against varicella. But if you took only one dose, after a few years, you will not have much immunity from the first dose and you will develop the disease. So he was probably having partial immunity from the first dose.
And in our time, you get the disease, you don't get the vaccination. So actually the immunity is strong.
You get the disease, then the vaccination. If you get the disease, no vaccination. You know, chickenpox, although people think it's a minor disease, it's really serious. We don't like to see it at all. Very serious, especially if you get strep A infection. I mean, we see kids with strep A infection after chickenpox. I mean, they can end up. I saw a case actually with necrotizing fasciitis in the neck and the back after strep infection after chickenpox vaccine. And another child almost about to amputate one of his limbs because of that. So it's very important to give this vaccine. Yeah.
It's not possible for HSV of
Yes, for varicella. It was positive from both. We took from the leg, we looked from the body. It's both positive for varicella. But at that time, we did not get the results so quickly. So after a few days, I mean, after he recovered, we got the results. But I agree with you. We should have done like the IgG, IgM at that time.
Because sometimes partial immunity for viral disease can lead to more aggravated viral infection. It has a mechanism of conformational shape of the virus itself, so it makes the infection more aggressive with partial immunity.
Okay, is there time for a third one?
Such patients should be also seen by a dermatologist.
Sorry, I did not hear.
Now, I mean, such patient should be also seen by dermatologists. Why you didn't consult a dermatologist?
Yeah, I don't remember if we called Dr. Shah or not. But this happened in American hospital, so I don't remember. But because we made the diagnosis, maybe we called them, but I really don't recall if we called any dermatology consultation on this.
We always call them, even we do the diagnosis, at least for the skincare.
Well, for his skincare, it was not that bad. You saw the regions; they are very few, but at least made the diagnosis. So the next one, so this we talked about this one. Okay, fever and leg pain again. But let's see, this is a little bit different. This is a 1-year-old female. She had 4-day history of fever and diarrhea, and her PO intake was acceptable. She was passing urine several times, previously healthy. But she was small for gestational age. When she was born, she was only 2 kgs. There is no travel history. The family deferred admission at that time. Usually a child with fever and diarrhea for 4 days, we are always worried about dehydration. So we wanted to admit her, but the family refused. However, they present 2 to 3 days later, and the fever was persistent. And also the diarrhea, and that was day number 7. Developmentally, she's appropriate for her age. She crawls, but she does not stand yet. Okay? And then the review of the rest of her system, according to the family, she had rash that lasted for 2 days, and then it resolved by itself. So we admitted the patient. Her weight is on the lower side. Height was okay, 25%. She had fever and was ranging in this like 38 to 38.8. Blood pressure is stable, heart rate is good. She's very cranky. And her physical examination showed redness in her throat. The chest, the abdomen, everything was clear. The skin did not have any rash anymore, but she did have the rash on the trunk a few days before she got admitted and resolved. And the extremities were normal, no deformity, no swelling, nothing. So when we admitted her, what do you think we should do? Like in her case?
Lab.
Yeah, just labs, the basic ones. So she had her labs, and we did the CBC. Nothing dramatic. I mean, her CRP 39, we see that with viral illnesses. Blood culture was taken. She was a little bit dehydrated. So these were her main labs. So basically, only the fever lasting so long. And the respiratory viral panel was negative. The stool studies, rota and blood pressure were negative, and the culture were pending. And urine analysis showed ketones, it was negative otherwise, and the culture was pending. Actually, when we have kids with this kind of prolonged fever, either it is a viral illnesses, most of the time, 3 to 5 days, viral illnesses get better. If they continued longer, then either we are talking about a superimposed bacterial infection or a different etiology, or a second virus just coming around the same time, so it looks like it's a prolonged virus. So taking the history is very important to make sure, because sometimes people come to you and say, okay, 10 days of fever, then you find there is 2-3 days gap without fever, which tells you that most likely virus after another virus. And of course, the superimposed bacterial infection, we have to think about it. Like if somebody has like URI and then develop ear infection or pneumonia or something like that, so they can present with prolonged fever. And there are some other conditions that can give prolonged fever, including rheumatology diseases. So this comes like next. So anyway, so this patient was, the imaging studies were not indicated unless anybody think that we should have done something about it for imaging studies. So basically, the differential diagnosis, like we thought it could be viral illness, acute gastroenteritis. We start thinking could be bacterial. That's why the fever is persistent. Does she have any sort of intra-abdominal abscess? And because she was so cranky and having this persistent fever, does she have like something like viral meningitis? Because that's one of the things that we see also with kids, and they don't have meningeal signs. So any child who's like very cranky with fever and persistent fever, we think about viral encephalitis or meningitis actually. So any other possibilities? And urine infection also is possibility, although urine analysis was normal, but does not always exclude UTI. So we have to think about UTI as well. So anything else for differential? Okay, let's see how she did. So the initial treatment, she was admitted, IV hydration, and we were monitoring for the progression of the condition, and we did ultrasound, and that was reported normal. On her hospital day, number 1, which was day 8, she still has fever. Diarrhea persistent. She has limited PO intake, and the child is cranky, no new signs. So what do you suggest to do? So she was admitted 24 hours before. But she is persistently having fever, and we could not find any reason for it.
Blood culture.
Yeah, it was done from the first day. And respiratory viral panel is negative, so really we don't have anything with us.
The GI panel.
GI panel, it was not available at that time. It's not always available. It can sometimes it's available, sometimes insurance does not cover, sometimes there is shortage. So we go through these cases. But usually, if we have a child and she is already on supportive treatment for 24 to 48 hours, we repeat the blood test. So this was suggested. So we have fever for more than 5 days, history of rash and pharyngitis. And I want to remind you with something. I said she has also, when we talked more about the history, we asked the family, they said the eyes were red at one point. Plus, she had rash. Remember, I told you she has rash. So put these things together. Fever, rash, history of rash, the conjunctival injection, the pharyngitis. Pediatrics should know. Huh? Strep? No, she's only one. You don't see like much streptococcal throat infection in this age group, like scarlet fever or stuff like that. But one of the entities, you remember we talked so much about MISC after COVID? It's similar to Kawasaki disease, okay? So when you have any child with fever over than 5 days with other criteria, we always think about Kawasaki. And sometimes even we think about Kawasaki, not even waiting for 5 days, sometimes second, third day, we start thinking about Kawasaki. So with this child having fever for more than 5 days, and the history of rash, the history of conjunctival injection. Actually, people will not voluntarily tell you about these things, especially the signs that disappear, like the conjunctival injection. We asked them, and then they said, yeah, we noticed something like that at one point. So we have these symptoms, so makes us think this could be Kawasaki. So the next step was to repeat and let me just mention, the Kawasaki, we have something called incomplete Kawasaki. What does that mean? Kawasaki, if you have all the symptoms, like the high fever over the 5 days, the rash, the conjunctival injection, and the changes in the mucous membrane, which is the redness in the throat, and the cracked lips, and then swelling in the hands and feet, and the persistent fever, like these 5 criteria. If they are there, this is Kawasaki, as long as there is no other etiology to explain the symptoms. Like if somebody, as you said, has streptococcus infection, for example, like scarlet fever or something, they might have similar symptoms with rash, with these symptoms. And one other sign that they might have also lymph node. Usually it's unilateral and more than 1.5 centimeter and cervical lymph node. But when you have not all the symptoms, part of the symptoms, and could not explain it, and the fever is going on for more than 5 days, we have to start thinking about incomplete Kawasaki that usually present with this persistent fever and some of the signs and symptoms. So in this case, what we did, we repeated the blood test actually. So we repeated this, and these are the numbers. Only 1 day after she was admitted, about, you can say, 36 hours. Apart from the previous one. If you remember the previous level, the white blood count was 12, now it's 19. The CRP was 39, now 120. And the renal profile is normal, LFTs is elevated, albumin is low. The albumin is low because this is vasculitis, so that's why the albumin is low. So anytime we have a child with high fever above for more than 5 days and other criteria like either anemia, like some blood or like laboratory or clinical criteria, like anemia or thrombocytopenia, hyponatremia, albumin, low albumin or elevated liver enzymes, we start thinking, or pyuria. We start thinking about possible incomplete Kawasaki, especially with younger age group, and she's only 1 year old. So it was suspicious for Kawasaki. And we end up doing an echocardiogram, and Kawasaki usually affect the coronary arteries. So she has some ectasia, and her abdominal ultrasound before I said normal. So we give her IVIG. This is the treatment for Kawasaki, and high dose aspirin.
You didn't do any immunological tests? C4?
Not usually. We don't do these tests. But the question is, where is the leg pain? Because this was the story. Where is the leg pain? Because this was fever and leg pain. So this child, after 3rd day, she still has low-grade fever, and she completed her IVIG. She's already on high-dose aspirin, and the family felt significant improvement after giving IVIG. And usually this is what we see in cases of Kawasaki. The child is a different person after the infusion of IVIG. Like within 12 hours, they can tell the difference. So they were very happy. And we give another 48 hours after completion of the treatment to see the fever resolving completely. Now, also we follow up with blood tests, but we have to give her 48 hours for the fever to completely resolve. But as I said, where is the leg pain? Because this was the title. So basically, on day number 4, she started having fevers of 39, and again the heart rate, and then she developed redness and swelling and tenderness of her right leg. And the right leg was warm, tense, and she was refusing to bear weight on it. As I told you before, she does not walk, she just crawled. But when we hold her, she will hold her leg. She will not put any weight on it. So there was no history of trauma or anything like that. So what do you want to do? And there was no history of cannulation. We thought maybe even from cannulation or something. So what do you think we should do, or what do you think is going on with her? Cellulitis. Okay, what else could be?
Oh, this is a new case.
No, the same. But after we treated the Kawasaki, she has this one. This is cellulitis. We thought about osteomyelitis, compartment syndrome, because this is vasculitis. Also was described in Kawasaki cases, but it's extremely rare. Extremely rare. So we consulted Dr. Suleiman, his father behind you. We consulted Dr. Suleiman, and he was not suspicious about this. He said, look for the donkeys, don't look for the zebras, look for osteomyelitis. So actually, we start thinking more about osteomyelitis or cellulitis. The swelling was really significant in this case. And what we did, because the fever was continuous, underwent a surgical incision with large amount of pus in there. And it was sent for culture. She started on clindamycin and aspirin was continued. Now, the culture grew MSS. And osteomyelitis of the tibia was confirmed with MRI. Honestly, we wanted to do MRI earlier, but the family refused. They preferred to do the surgical, but not the MRI. I don't know why. But we convinced them to do the MRI to make sure no bone involvement. And there was bone involvement. So we were able to continue the treatment for 6 weeks, partially in the hospital, and then the rest was oral. And the repeat echocardiogram was normal, and so she was treated for Kawasaki and for osteomyelitis. Now, the thing is about this case is because we are used to talk about Kawasaki like with one of the criteria for Kawasaki, no other condition that explains the symptoms, like strep infection or staph, or in this case, osteomyelitis. Oh.
What about adenovirus conjunctivitis or adenoviral infection? It's similar.
Which virus?
Adenovirus.
Yes, of course. Usually we have cases that we admitted, but how we can tell? Of course, in this case, we did the respiratory viral panel is negative. We have cases that have adenovirus, and they presented exactly the same way, and they have also very abnormal lab tests, including CRP. They give a sepsis picture in their lab investigation. But the clinical progress is different, because in these cases, usually we see the platelets going high, and we don't have explanation. In adenovirus, it's almost within 4 or 5 days they recover. These are more than 5 days history now. This one 8 days. Although in some cases they can have viruses that can last longer. So anyway, so the vital signs stabilized, the right leg got better, and everything normalized, and she completed her treatment, and she was discharged. What I want to say, there are several case reports in children with Kawasaki disease in association with osteomyelitis. And this supports the theory that says bacterial infection equals what we call super antigen hypothesis, and it can trigger Kawasaki syndrome. In fact, we have to think about it in any child. Like Kawasaki syndrome, it should be considered in association of bacterial infection if there was a partial response to treatment. Let me explain it in another way. There are cases, because this case, we diagnose the bacterial infection after the diagnosis of Kawasaki. Now, what happens sometimes is the other way around. You have the bacterial infection and you treat the bacterial infection, but this response is not complete. And the child continues to have fever and continues to have elevated inflammatory marker, although you feel like you already are treating the infection. In these cases, the underlying cause for this persistent fever is Kawasaki disease. That's what we don't want to miss. So the presence of bacterial infection does not rule out Kawasaki disease, especially in small kids. There were case reports on newborns, and I won't say newborns, like 3-4 months old, who were very sick with bacterial infection like staph or strep infection, and then they end up having Kawasaki disease. And the reason they discovered Kawasaki disease because they can continue to have persistent high fever. Then somebody decided to do an echo, and they found the changes in the coronary artery. So anytime you don't see the response that you want to see in bacterial infection treatment, you need to start thinking a little bit further about the presence of Kawasaki disease.
Do you think is that the IVIG treatment or treating Kawasaki didn't aggravate the infection? Because it should be started from
know, to be honest,
it should be started from number one. Number one, yeah, because
why IVIG will
it's considered as immunosuppressant.
well,
or
but
immunomodulation.
it is only within 2 days.
Yeah, but it's enough. It's immunomodulator.
2 days to give osteomyelitis.
And also, I would suggest also do some complement tests, because, as you just mentioned, super antigen. What's the definition of a super antigen? Is an antigen which can directly stimulate the immune cells, especially the lymphocyte, without being presented and processed by the antigen presenting cell.
But
It
it
is
is not as
bypass.
a usual complication of IVIG.
Yeah, but it's not a
We
complication,
are
it's
working
aggravation.
too many with IVIG. I never see a case after IVIG with any bacterial complications.
Yeah, but
I think it's also too small.
the bacteria was there. It aggravated. It is started by leg pain, so it's already the infection.
And
was there.
IVIG
The
is
leg
not
pain,
an
we don't know when it
immunosuppression.
starts. We
Immunomodulator.
noticed after we saw the
Later, but
signs.
this is not immunosuppression.
No, it immune modulates, so it might affect the immune response to any infection.
Indeed, the leg pain was there from the beginning.
We don't know because
This is why
she is
we give it
one
an autoimmune
and she does
disease.
not have any changes on her extremities and she does not walk. So she was very cranky. Maybe she has the pain, and I believe she did have the pain, but we were unable to discover it because of her age. But definitely she has the diagnosis of Kawasaki because she met all the criteria, including the platelet count later, went up to 1.5 million.
Dr.
And this is
Hanan,
one of them.
what does it mean high dosed aspirin in this case?
We use actually for treatment of Kawasaki. We don't know the cause. We know the treatment. The treatment is mainly IVIG. The aspirin, we are not sure if really does the work or not. But the protocol that they studied is high dose, which is 80 to 100, actually 50 to 80 milligram per kg per day, divided in 4 doses. And then after the fever subsides, and for 48 hours, we switch to a low dose, which is 5 milligram per kg per day for 6 weeks. Because at this stage, we have the biggest issue is because of the coronary artery involvement and the development of aneurysm. So we want just to give antiplatelets medication so they don't coagulate and cause clots. So just more like.
And IVIG, according to the standard dose?
It's 1 to 2 milligram per kg. There are different doses that
1
were
to 2
studied.
gram or
Gram or
gram? 1 to
Gram.
2 gram per kg.
Yeah, gram. What did I say?
Milligram.
No, gram. 1 to 2 gram per kg. There are studies that they studied like 1.4, 1.8, but actually when you are 1.6 or 1.8, there is not much difference in the outcome. So the standard is 2 grams, per kg.
For 5 days?
No, we give only one
Only
over 12 hours.
Yeah.
Then we wait for the response. As I said, it should be within 48 hours. The fever should subside and resolve. If still there or going up, or sometimes they can have the symptoms like 4 or 5 days later of the treatment. They start again with high fever. Then we give a second dose. And if there was no response from the second dose, we use steroids. Sometimes we use steroids from the first day. Depends on the involvement of coronary arteries and depends on the etiology. So post-COVID, we are seeing many cases of this risk, and it's similar to Kawasaki. And for these cases, we are treating exactly the same thing. Only difference is if there is coronary artery involvement from day one, we start steroid with this.
Well, we use a lot of immunomodulator and immunosuppressive, either maintenance or induction in nephrology. So once we suspect the infection, we cover with antibiotic if it is urgent indicated. Even if it is planned, we check for TB by T-spot test or interferon-gamma test. And if it turns positive but latent, not positive disease, we give the prophylaxis anti-TB with this immunosuppressive or immunomodulator. If we suspect bacterial infection, we cover with antibiotics. This is what we do in nephrology in other for autoimmune disease like glomerulonephritis or post-transplant. Might be different, but it's very good. Okay. Next time, fever and the upper leg pain, huh?
I get you. Yeah, but this is what we have.
We have to find fever and the upper arm, upper arm pain. Excellent.
Thank you so much. Thank you.
Fever and the upper arm. You have to find the cases. Fever and the upper arm.
Yeah, next time.
Thank you so much. It was nice.
Good.